Thank you very much. Craig, thank you. Strange thing, speaking to Senator Specter for a moment, strange thing how rapidly the political process has sort of devolved since Arlen's passing. I've received 2 awards in the last year. One at the University of Notre Dame at their commencement, the highest honor that the Catholic Church gives, and one recently by a university here in Pennsylvania that has become widely recognized for being able to work with the opposition, for being having strong relationships with my Republican colleagues. And in both cases, I almost turned down the award, not because I'm not flattered, but because it is an indictment of how far the system has temporarily deteriorated. Arlen Specter and I were truly, truly close friends. There's John McCain and I, and John has an extremely volatile temper, says things like Biden should be taken off the ticket, he's incompetent, and then apologizes. But all kidding aside, I miss Arlen. I miss him personally, and I miss him in terms of his contributions to making a system work. The opposition is not the enemy. It's the opposition. It's the opposition, and it is a little bit like reminding me of your the motto of this organization. If I could do anything, I would like to see the motto of this organization, which I'm trying to find right now. Hang on a second here. Here it is. In a democracy, agreement is not essential. Participation is. Go back to the beginning, guys. The fact of the matter is that we're not participating very well together. And it's got to change. And I thank organizations like yours for insisting on the great issues of the day being discussed and debated, and hopefully attempting to find some consensus. I want to congratulate Dr. Fajgenbaum for the award he received tonight for his tireless work to find a cure for Castleman's disease at the University of Pennsylvania. And Dr. Glasnow and Dr. Knudson, congratulate you on your award as well. The Sidney Kimmel Cancer Center at Thomas Jefferson is a world-class institution. I know my son was there, and I know my son-in-law is one of the leading surgeons in the Delaware Valley who is also there. The reason I'm late is all Howard Krine's fault. No, it's not. I was going to say I'm Joe Biden, I'm Howard Krine's father-in-law. But it's great to see you, Howard. Great, great, great universities, great teaching hospitals. And it's great to be back at the World Affairs Council. I've spoken here on numerous occasions, but particularly today to receive the Atlas Award tonight. This has always been a place for serious discussion, important issues grounded in your maxim, as I said before. In democracy, agreement is not essential, but participation is. I had the privilege to speak here, as I said several times. The last time I spoke here, I was a United States Senator in 2006. And I spoke then about how to stem the horrific sectarian civil war that was engulfing Iraq with our brave troops caught in the middle. I hope I'm as right about the moonshot as I was about that day. The truth of the matter is there's no way Iraq can be settled without a federal system being in place. There's no way one strong central government can control all of Iraq. They're both extremely complicated issues, cancer and Iraq. But I've found nothing more challenging or complicated than cancer, because there is no single cancer, as so many of you know. There are over 200 distinct forms of cancer, not all susceptible to the same diagnosis or treatment. But I'm convinced we can make significant progress in a short amount of time, and in the process, extend lives as well as save tens of thousands of lives. We all know the reasons why it's so important to move forward with deliberate speed. Today, there are approximately 14 million new cancer cases a year, 8.2 million cancer-related deaths worldwide. And you are representative of every major audience we could put together in this room, the number of you that raised your hand, who've lost someone close to you, someone you loved, a family member, or someone very close. By 2025, if the status quo ante is sustained, the world will see almost 20 million new cancer cases per year, with 11.4 million dying per year. Cancer is taking your loved ones and mine, robbing them of decades of productive life. When I announced my decision not to seek the nomination for president, the president said, "Let me accompany you to the Rose Garden while you make that announcement." I decided after my son succumbed to glioblastoma that it just wasn't appropriate for me to run. And although I had a brief press statement, I said, and I don't even know what made me say it, but I said, in effect, the one regret I have in not running, I would, if I could do anything as President of the United States, it would be to preside over ending cancer as we know it, because I think it's possible. The cancer moonshot grew out of that statement. The president didn't even give me this authority over the federal government. And although we had discussed the need to redouble our efforts, in essentially executive order he signed, he gave me direct jurisdiction over every agency of the federal government that has anything to do with the possibility of dealing with cancer, from the Veterans Administration to the NIH to the Department of Energy. And since then, I've traveled the world and the country, touching a significant number of the major nerve centers in the fight against cancer, both here and abroad. The purpose of that basically tour over the last better part of 8-10 months was to see if I could get a sense from the leading minds in the world, what are the avenues that we should be pursuing, that we're pursuing now that we could do better, or that we're not pursuing and we should pursue, to get their ideas of how to double the rate of progress with regard to cancer. Some suggested that we had said that we were going to cure cancer. We never said that. But we think we can make exponential progress in treating cancers and eventually curing most cancers. And in the process, I have literally met, and Howard's been with me in many of these. He works on the Cancer Task Force in Washington with me. I've literally met spoken to well over 9,000 cancer researchers of the two largest organizations. I've met at 11 of the major cancer hospitals, from Penn to MD Anderson to the Hutch and all around the world. And I've spent hours in roundtables with the leaders of each of those institutions. And I've never met a more dedicated, brilliant group of individuals in my career, and I have a long career. And wherever I go, and I talk about what may be possible in fighting cancer, I've now realized there's a consensus among the experts that we've reached an inflection point. It did not exist even 5 years ago, and it's just beginning. Let me explain what I mean by that. As little as 5 years ago, oncologists weren't routinely working closely with immunology. 10 years ago, immunologist was like a voodoo science. It had started in the late 1800s and early 1900s and been abandoned. So now immunologists, virologists, geneticists, biological and chemical engineers, they're all working together for the first time, sharing their enormous amount of raw, fundamental science that they each know in a different way. And today, there's a recognition that by aggregating and sharing data from millions of patients, their genomics, their family histories, their lifestyles, their responses to treatments, the treatment outcomes, that we have the potential to find new patterns of causes and successful treatments of cancer. And unlike even 10 years ago, we now have the capability, as a consequence of absolute quantum leaps, no pun intended, in technology and supercomputing, that will allow us to analyze enormous amounts of data in a matter of seconds. We now have the capacity to do 1,000,000 billion calculations per second. 1,000,000 billion calculations per second. The Department of Energy will, within the next 3 years to 5 years, be able to do 1 billion calculations per second. With an aggregation of significant amounts of data, we'll be able to use this computing capability to find answers that could literally, and patterns that could literally take a generation of individual or groups of scientists sifting through it to garner results from. And there's been great strides, as many of you know, because there's docs in this room, great strides in genomics. Because of technological advances in analyzing the genes, cancer genes as well as all other genes in the body, we're closer than ever before to understanding what causes cancer, knowing better how to attack particular cancers. You see, cancer is a genetic disease. So understanding what genes have mutated and their effect on cancer is important for doctors to determine the right treatment for patients. A few years ago, it took more than a decade and $2.7 billion to sequence the human genome. Now, it takes less than a day and costs under $1,000. And by the next time, if you ever invite me back, although I won't hold public office, it'll probably cost closer to $200 and be able to be done in a matter of hours. So there's even more, now there's even more reason to be hopeful. New technologies, new therapies can target cancer cells, but do less damage to healthy cells. Transform many types of cancers into chronic and manageable diseases, where 10 years ago they were a death sentence. Some of you leading docs out there know that we're learning that the way in which we've treated cancer the last 40 years is not only, how can I say it, difficult on the patient, but maybe mistaken. High doses of radiation after excising the tumor. We're now finding out that those high doses kill the very immune system that can be used to fight the cancer in many cases. We're finding that low doses of radiation can have not only a palliative impact, but an actual positive impact on dealing with the cancer that may remain or be excised. Last Sunday, the front page article in the New York Times by a reporter named Denise Grady looked into one of those therapies. Now, I always kid my staff. I don't actually kid them. I drive them crazy. Through my career, I would always say to a press person or anyone who wrote a speech for me or an outline of a speech, I said, if you can't pick this press release up or this speech, pick up the phone and call your mother or father or friend, educated, well-educated or not, read it to them once, and they say, I understand it, then don't give it to me. I'm not joking. I joke and I say, I need you to speak English, not as opposed to Spanish, but as opposed to complicated. And what really good reporters are able to do, and in my view, I don't know Denise Graves, are able to translate, without talking down to people, complicated notions. And if you saw that front page article in the Times on Sunday, you got a sense of it. I'd like to read a small part from her article. She said, the immune system, a network of cells, tissues, and biochemicals that they secrete, defends the body against viruses, bacteria, and other invaders. She goes on to say, but cancers often find ways to hide from the immune system or block the ability of the immune system to fight. Immunotherapy, and you have some of the leading people in the world, one of the leaders in the world right here at the University of Pennsylvania, immunotherapy. She said, immunotherapy tries to help the immune system recognize cancer as a threat and attack it. You say, I get that part. That's pretty easy. In the last few decades, there have been great advances in immunotherapy, including Suzanne Torpolin at the Sidney Kimmel Comprehensive Cancer Care at Johns Hopkins University, and Carl June at the Perelman School of Medicine here at the University of Pennsylvania, probably the leader. A number of philanthropists are funding major new immunotherapy initiatives at these great cancer hospitals. Sean Parker, Mike Bloomberg immediately come to mind. Mike asked me to go with him to Hopkins to speak to them at Hopkins. And he said, if you go, I'll make a contribution. I said, great. He showed up and he wrote a check for $250 million. I said, where the hell have you been, Mike, my whole life? But there's philanthropists making significant commitments. There's great competition, as Howard knows from traveling the country with me, of each cancer research center saying, we are the center of immunotherapy. I like the competition, but sometimes a lot of money and time is wasted, but I'll get to that in a minute. So the article went on to explain how these researchers are focusing on two different types of immunotherapies. One type generates a personalized treatment for each patient's particular cancer after the cancer genome is read. From patients' blood samples, doctors identify immune cells called T cells that kill the invaders of the body and find the ones that are doing the best job in targeting cancer, and then through a blood transfusion, they extract those cells, multiply them in the hundreds of thousands and millions, concentrated in a laboratory, and re-inject them back into the bloodstream of the patient. In other cases, the doctors will extract the patient's immune cells, the T cells, and then genetically engineer those T cells of that patient to hunt down and attack the particular cancer identified that the patient has, and re-inject them into the bloodstream. This approach is very expensive. It requires a type of personalized biomanufacturing because each and every treatment has to be tailored to the individual cancer in the individual patient. There's a second type of immunotherapy, drugs called checkpoint inhibitors. Now, I know a lot of you know this, but excuse me for being so pedantic, but I think it's important that we know all the basics here. Let me explain what a checkpoint inhibitor is. The immune cells in your body and mind, by and large, are very effective. But to keep these killer T cells, for example, from attacking healthy cells, Mother Nature put into each of these T cells a braking system to prevent the immune cells in your body from attacking the good cells in your body. They call them checkpoints. But here's the problem. Cancers are smart. They have found a way to hide from the immune system, preventing the T cells from finding them and attacking and destroying the cancer cell, not allowing the immune cell to do its job. Because what they learn to do is they learn to kick on this checkpoint. Basically saying, I'm a good cell. The checkpoint kicks on and does no damage to them. But so-called checkpoint inhibitors take the brakes off the immune system, unleashing the T cells to detect and destroy cancers that otherwise have been effectively hiding from an immune response. Unlike other types of immunotherapy, these drugs, checkpoint inhibitors they're called, they don't need to be manufactured separately for each individual cancer. And there are several checkpoint inhibitors on the market today that have been approved. One of them, the best known now, is Keytruda, which is now being called the Jimmy Carter drug. The drug allowed the immune system in President Carter to attack the melanoma that had metastasized and spread to President Carter's brain. Ordinarily an absolute death sentence. It worked. At least for the time being, he is cancer-free. There are 3 others, checkpoint inhibitors, that have been approved. The point is, these drugs have helped thousands of people, many who thought they had reached the end of the line with no treatment options, no hope, go into remission, giving them years of life, maybe them ending up, as they pass, having nothing to do with the cancer they had contracted. But there's a problem. Checkpoint inhibitors work on some people, but not on others with the same exact cancer. By some estimates, these checkpoint inhibitors are effective between 20 and 40% of the time. There's a debate about how effective they are, how often. The real question is, why are they not effective 60 to 80% of the time? God forbid the front row of the head table all contracted a similar cancer, received a checkpoint inhibitor. 3 of you would live. The others would not. Why? Why? This is one of the critically important questions that Dr. June and so many others are trying to figure out how to answer. We have to find out why. As I said at the beginning, we've reached the inflection point. We have improved how we work together. But let me put this to you colloquially. Up until now, we've been fighting cancer. We haven't been fighting cancer. We've been studying cancer. Instead of soldiers in the war against cancer, we've been students majoring in cancer. This has to change. We have to make ending cancer as we know it a critical mission, time sensitive. Simply put, that means we have to change our approach to the way we've been fighting cancer. We've made progress, but the status quo ante will mean we'll make only very incremental progress the next 25 years. Remember at the outset, I said I travel the country and the world visiting most of the major cancer research centers in the world, thousands of oncologists and immunologists and others. There is, in my view, an emerging consensus among all the folks I've met as to what kinds of changes we need to make to change our approach in battling cancer. In just the last 4 months, my task force has come up with a series of collaborations, 40 in all, that are intended to change the way we do business in the cancer world. And just in the last 4 months, that task force, working with the private sector, has agreed on these initiatives and strategies for achieving our mission. And I'm just going to mention 5 of these strategies, and it will not take long, where there's overwhelming consensus among the experts in the overlapping fields as to how we can make more progress more rapidly. First, there's a consensus that we have to realign the incentives of the research system. The federal government puts out billions of dollars a year in cancer research grants, as do other institutions. The problem is, to better promote breakthroughs and speed up progress in preventing and treating cancer, we have to change the way we do it. Right now, too many scientists and researchers have to focus on writing the next grant request to continue their existing research and keep their laboratories open. And not enough time taking the next step, taking the next leap, for fear that they'll lose the funding they have. We have to change the culture of research that turns scientists into grant writers and discourage them from taking risks. And it's not their fault. It's the way the system works. You take a risk, you don't get funded again, your lab is in jeopardy. We have to change our academic and publication systems so the research papers that they come up with as a consequence of these efforts are available at no cost with no time lag. Now they can cost as much as $100,000 in the publications that they're published in. And they're hidden behind a wall for a minimum of a year before they can be shared. We have to make the research data open so it can be used in subsequent studies and cited back to the original investigator so that we reward teamwork. Right now, that's not how it works. One person gets the recognition, discouraging the prospect of teamwork. And by teamwork, I mean people from different research institutions and disciplines working together to move forward faster. There's also consensus on how we can generate, share, and integrate data from cancer care, from family histories, from gene sequencing, from anything that relates to the patient or their condition, with the ultimate goal of enhancing patient care. To do this, we have to create a better system that can share data and that can empower patients to take the data that they have themselves control of and make it available to repositories. I don't want to make this personal. It's not about me, but you've had the same experience with your family members. My son was in a research study of one at the end with a very experimental decision to go in a very experimental way that had never been tried before. He was up here at Jeff, and then he was at Walter Reed. It looked like it worked marvelously for a moment, But what he had to do is he had to have an MRI done at least once a day, or not MRI, it was an MRI, once a day. Well, you know, we talked about electronic record sharing to speed things up. Well, guess what? There was no way for Jeff and or Walter Reed Hospital to communicate the results of that MRI to MD Anderson that was overseeing the treatment. So this guy had to figure out how to take a picture on a cell phone and or get them to put together a disc that we'd fly down to MD Anderson. I'm Vice President of the United States. I have access to all kinds of help. Imagine the father from Scranton trying to get his son or daughter's information to the major hospital treating them. This is 2016. Some of you are extremely successful businessmen and women. Can you imagine running your enterprise the same way? That's not the fault of the researchers. It's the fault of the way we've set up these silos. We put $35 billion in the Recovery Act because they're told by every expert. The President and I actually did that ourselves, put it $35 billion in to allow for electronic record keeping because we were told all the benefits. Well, guess what? It generated 5 institutional bidders that spent $5 to $7 billion apiece with systems that don't talk to each other. And guess what? No incentive to want to talk to each other. Because then the uniqueness of your system no longer justifies you reaping the financial reward. It's not the researcher's fault. Imagine that in Silicon Valley or on Wall Street or in astrophysics. If the data is aggregated in large numbers, we can use that supercomputing power to discover patterns in the data and find answers that couldn't have been found just 5 years ago. As I mentioned earlier, why would one immunotherapy work on one patient and another diagnosis exactly the same and not work on that patient? If you get 100,000 people in there of the million that are in this aggregated data, you can begin to find patterns. Without this computing capacity, this would take years, as I said. In other sectors that receive government funding, like physics and astronomy and astrophysics, scientists share whatever information they uncover seamlessly and ubiquitously all the time. And they must do it immediately. 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 Some of it arguably could have national security implications. But it's shared ubiquitously, immediately. Somehow, in medicine, it's a problem. Third, we have to bring new prevention strategies, diagnostics, and therapies to patients in communities across the country and across the world. Last month, I went to Cleveland, and I saw a tobacco cessation and cancer screening program, a collaboration between George Washington University and Case Western Comprehensive Cancer Care Center at Case Western University. Both of these programs use social media and digital monitoring techniques to help people adopt healthier lifestyles. And they're already making progress on how we can communicate how to change those lifestyles. But there's a second thing. There are also new diagnostic tools becoming available almost daily that allow detection of a cancer very early.
Some of these new diagnostic tools include new non-invasive mobile imaging techniques, the ability to detect genetic markers that will allow you to identify those at risk for developing cancers long before the cancer is developed, as well as new, less invasive tests on colon cancer. And there's a lot of research being done at great universities and companies developing what's being referred to now as liquid biopsies, where doctors literally have a blood test, take a vial of your blood, looking for those markers in your blood by testing that vial of blood, alerting you to cancers, some of which take 20 years to develop. But if you identify the marker, you increase exponentially that you will not die of that cancer. We're working to accelerating getting treatments to patients by identifying any unnecessary regulatory barriers that exist in the federal government, things that get in the way of researchers. I've become sort of the Darth Vader of the federal government because everybody knows I mean what I say. If they don't eliminate the bureaucracy, they're going to be fired. Not a joke. Not a joke. I'm deadly earnest. Like getting access to experimental drugs, if it's a case of last resort, accelerating approval process for breakthrough drugs if there's no existing treatment for that cancer, encouraging and requiring more trials of cancer drugs and children's cancers. At the National Institute of Health, we've launched a new partnership bringing together biopharmaceutical companies, major cancer research centers, foundations, and philanthropies to collaborate on early-stage research and share all of the data everyone involved in the research is engaged in. So instead of 20 companies each studying the same thing at early stage and not sharing it, they study the same thing together and share all the data at early stage. Drug companies have come to realize that this is very much in their interest, not to replicate the basic science. We've streamlined collaboration therapies, that is, the use of more than one cancer drug in a treatment, just as we did in AIDS, which potentially improves the likelihood of cutting and curing a particular cancer. Up until just several years ago, if a cancer drug by XYZ, X Corp or X pharmaceutical company, and another one treating a similar cancer from Y, if you said, let's put them both together and use them in the same study, each of the companies said, no, not my drug. Well, that's changing. That's changing. For example, we just announced at the National Cancer Institute formulary, a public-private partnership with 20 so far, close to 30 now, pharmaceutical and biotechnology companies thus far, with hopefully many more to come, which allows researchers to test existing drugs for new combinations that could be effective. That is, each of those companies agree they take all of their drugs they've developed and put them in one place. Any researcher can come along and say, I want to use your drug, 2 of your drugs, and 3 of your drugs. Here's how it works. When you go into a bar and you want to listen to a song on a jukebox, you don't have to negotiate a licensing fee for each song from a record company. That's already been worked out. But until recently, if you wanted to use a combination of drugs, you had to go to each company, get permission to use the different drugs, and work out ahead of time the intellectual property concerns. And it took years. Now NCI will cut the deals, intellectual property, access licensing, and researchers just have to pick the drugs they need and move forward with the research. And if they hit the jackpot, it's already determined who gets a piece of what. This will make an enormous difference. Combination drugs have the potential to do for cancer what they did for HIV for the 3rd time I've mentioned it. The 5th area of consensus is we have to increase access to clinical trials. Less than 5% of the people who are diagnosed with cancer have access to a clinical trial. We have to increase access to clinical trials for both the patients, whose primary hope is to be in a clinical trial, and for the drug companies, who have considerable difficulty generating a sufficient number of patients to conduct the clinical trials. Patients should be able to seamlessly find a clinical trial that might suit their specific condition, and the doctors should have an easy way to guide their patients through the process. As I said, less than 5% of all the people in America, it's lower worldwide, who are diagnosed with cancer, enroll in a trial that might be the key to discovering the next life-saving treatment for them and others with their cancer. The existing online database has proven to be too complicated for most patients and physicians to be able to navigate. So under the moonshot, we've created a new site, trials.cancer.gov, to help people learn about and get access to cancer clinical trials. We're making great progress, breaking down silos, getting government and non-government and for-profit and non-profit sectors to work together. Earlier this summer, I hosted a Cancer Moonshot Summit, where for the first time in history, physicians, scientists, nurses, patients, advocates, families, cancer survivors, foundations, companies, and institutions all came together. More than 7,000 individuals gathered at one time in more than 260 summits in all 50 states, Puerto Rico, Guam, and the District of Columbia, all under the national charge to make decades worth of progress in 5 years in prevention, diagnosis, treatment of cancer. And I'm insisting at a federal level that we practice what we preach. For example, in June, I went to Chicago to launch the National Cancer Institute Genomic Data Commons at the University of Chicago. Before my son had cancer, I would have assumed this thing already existed. It's a platform that includes the genomic data associated clinical data from tens of thousands of patients in the federal system. The largest hospital in the world is the VA. There's millions of patients at the VA who have been treated for or diagnosed with cancer. Thousands of these patients, full sequencing and all related information to what they have, is now shared openly and broadly to advance cancer research to improve cures. It's a data commons. Any researcher can go to it. They don't have to be part of a hospital chain. They don't have to be part of Cancer Link, or they don't have to be part of Orion or these other good outfits, but that basically hoard the information that they have. I mentioned only a few of the 40 announcements that we made thus far, and there'll be more to come. All of these initiatives are designed to seize the moment, move with deliberate speed and purpose to double the rate of progress. We need to discover the molecular mechanism of which genes drive which patient's tumors, why certain cancer patients respond to certain therapies and others do not, how cancers become resistant to specific therapies, and what combination of therapies can prevent resistance and deliver cures. Imagine the day, perhaps in the lifetime of my grandchildren, at least in their children's lifetimes, when the threat of cancer is a distant memory. This is not wishful thinking. It's within our wheelhouse. When their children can be vaccinated for cancer as routinely as they're vaccinated for measles and mumps. Unless you think this is a pipe dream, we already have vaccinations to prevent cervical cancer, the HPV vaccine, just like vaccination for measles. It prevents cervical cancer. Other cancers can be treated, cured, made into chronic conditions. We're on the cusp of breakthroughs that can get us there, and the goal of the moonshot is to propel us forward, not someday, but now. The urgency of now. All of you know, because of those who raised your hand, for everyone you lost, every hour, every day, every month matters to someone diagnosed with cancer. Think of how many people have said to their docs and said to you, "Doc, just give me long enough to walk down the aisle to give my daughter away. Just give me long enough. Doc, I just need another year to get this deal done so I can leave my wife and my family in good financial shape. All I ask for is 8 more months. Doc, all I need is 2 more months. She's graduating, Doc. She's graduating." We need the urgency of now. Now, not tomorrow. And it's within our wheelhouse, not to cure, but to begin to do more than incrementally change the prospects. Can you think of any diagnosis, including Alzheimer's, that is worse and more dreaded than, I'm sorry to tell you, you have cancer? You're a really sophisticated audience. I strongly urge you to do all in your power to insist that we break down these silos. Many of you in here are significant philanthropists. Thank you, thank you, thank you for what you're doing. But most of all, remember, in this country, there's never been anything we said we can't do. Never. We've lost a little bit of that mojo as a country. It's within our wheelhouse. And this is not hortatory. This is real. There's so much more to say, but I've said much too much already, except to say, those of you who've been through it, you know. You know how important it is. So thank you all. May God bless all those suffering from a diagnosis now. And may God protect our troops. Thank you.